Great.
Thank you so much for joining us, Dr. Hamilton. Do you want to just introduce yourselves for our viewers?
Sure. I'm Barbara Hamilton. I'm an adult cardiac surgeon here at the University of Michigan. I'm an assistant professor of cardiac surgery. I am Canadian by birth, but did all my medical training in the United States. I went to medical school at Columbia University in New York, and then did my general surgery training at the University of California in San Francisco. I stayed there for cardiothoracic surgery fellowship, and then came here for aortic super fellowship, some additional specialized training after my formal training. And then they hired me as an aortic surgeon. So
very nice. Wow.
Here I am.
Awesome. So take me back to where this all started. Where did your path to medicine begin?
Sure. So I don't have a traditional path.
Okay.
I was interested in being a doctor since probably I was quite little. I did competitive lifeguarding in high school, which is sort of a combination of a swim meet and a fireman's competition type paramedic thing all at the same time. And so I really enjoyed a lot of the life-saving skills that I learned doing that. But I also played music. And so when I was graduating from high school, I was all set up to do pre-med at the University of Saskatchewan. And I played in a band, and the director of the band was also the director of jazz studies at McGill University. I played trombone. And so he said to me at the end of the camp, I have a spot for you at McGill, and I want you to come and be in my music program. Wow. And I was like, oh, no, I'm going to go be a doctor. And my dad wonderfully said, hey, you can always go do that, but this is a neat opportunity. So why don't you go to Montreal for a year or two, play music, and then you can always transfer over. And then a year or two in Montreal turned into finishing the degree and then being an artist in residence at the Banff Center for the Arts for a year. Wow. Then I moved to Amsterdam and studied at the conservatory there for a year. And then I moved to New York and did my master's in jazz performance at the Manhattan School of Music. And then I was living in New York and freelancing and in my mid-20s, and realized, well, hang on a second, am I just going to play music for the rest of my life, or am I going to continue that dream of going to medical school? Right. So at that point, I did some volunteering in hospitals, and then I also sat in the back of some science classes at Columbia, actually, which was across the street from the music school, and realized I really needed to pursue it. So then I had a whole other thing going on, getting my prerequisites done and studying for the MCATs, and then was fortunate enough to get to stay in New York at Columbia because it was a nice sort of dovetail out of music into medicine with staying in the same spot.
All right. Wow. Yeah. And then medical school, right? So talk to me about like what that was like.
Yeah. I mean, it was really fun.
Okay.
Columbia was full of, there was a whole cohort of us that had other careers and then gone to school. And so I had a number of, I mean, they're probably still my best friends to this day who had also done other things and had other interests. And, you know, we were all starting med school in our late 20s, which was nice to do that together. I think it was also fascinating to dive into this completely different world after having inhabited the music world for so long. So I enjoyed it a lot.
Wow. Yeah. Were you able to do music on the side while you were
I did. Yeah, I played in the Columbia University Orchestra while I was there, and then I was playing with a couple big bands in town, which was nice. Yeah.
Well, I didn't catch what your instrument was.
Trombone.
Trombone. Yeah. Very nice. Wow. Yeah. That's amazing. And so after medical school, it was residency, right?
Yes. So the you know, coming into the end of in hindsight, it makes complete sense to me that I'm a surgeon. But at the time, there was a lot of pressure I felt maybe that I put on myself. You know, I was older. I knew I wanted to have a family. I knew I wanted to be a mom. And I felt like the time commitment that was necessary for a surgical subspecialty or a surgical specialty was too much, that I needed something a little shorter. So I tried really hard to like emergency medicine. And I knew I wanted to do something with my hands, something procedural. And then once I realized it was going to have to be something surgical, then I tried ortho and I tried ENT, and I, you know, tried to find some surgical subspecialty that had like a good lifestyle but would still be surgery. And I knew that the chest pulled me the most. But I was completely not ready to commit to cardiothoracic. So in the end, I settled on general surgery because it just kept so many doors open, and there's so many things you can do out of general surgery. So it made the most sense for me. And once I decided that, which I did very late in medical school, I actually had a bunch of sub-Is set up that I had to totally shift around at the last minute. But once I decided that, I could actually sleep again at night. And I knew I was making the right decision at the time. So I took the traditional path to cardiac, but I really enjoyed that.
I mean, surgery is so competitive. How did you make yourself stand out in medical school to match?
Yeah, I mean, I think it's challenging. For me, it was, I had a sort of a leg up in having had this other career as a musician, because I took it pretty far, and I was involved in some, important things that occurred. And so my resume has, like, I had gotten a number of grants and awards and things like that. So it made it,
that always helps.
It helped, even though none of them were science related. And I think that's a key thing that can really make you stand out, is when you show that you have passion for something and that you are willing to work consistently hard for something that you're really passionate about, that you will get somewhere with that. And it doesn't have to be science related or medicine related, or the sort of traditional silos. It can be something completely different, but if you achieve something of importance there, it shows that you have the ability to discipline yourself and consistently, persistently work at something, and that those qualities will do well for you in medical school.
The resilience parallels, essentially.
Absolutely.
So then talk to me about residency as well. How long was your residency?
So my residency was a little over 7 years, because I had 2 kids during residency. I was at UCSF, and so I did 2 years of research in between. And so 5 clinical years and 2 years of research, and then things got a little bit delayed because of maternity leaves, such as they are. But I mean, I loved general surgery. I loved you get to do so many different things. And so, 1 month you're on trauma in the county hospital, like slashing people's chests open in the emergency department to squeeze their heart and hopefully get them through. And then the next month, you're doing reconstructive breast surgery for breast cancer at, a completely different kind of surgery center across town. So I think that the plethora of opportunities within it was really fun. But as I was coming to the end of it, it was really clear to me that cardiac, and I should say cardiothoracic, really, that both lung and heart surgery were the most appealing to me. General surgery was so broad, but there were pieces within general surgery that really resonated with me, like the acuity of trauma, like the finesse of vascular surgery. And I knew that I needed to find a specialty that pulled all those things together for me, and wonderfully cardiac was that specialty.
Did you have any really significant mentors during residency that really affected that decision?
Yeah, that's a great question. I had some really fantastic non-CT surgery mentors. And then I had a really fantastic thoracic surgery mentor. And so coming into fellowship, I wasn't actually sure whether I wanted to do cardiac or thoracic. And then as soon as I started doing cardiac consistently, it was really clear to me that of the 2, that's what I enjoyed the most. But I had such strong thoracic mentorship that I was pulled in that direction initially. And we did, UCSF does a lot of lung transplant. And so I had loved those cases a lot. But it's hard, because at that time, I didn't work with any female cardiac surgeons. And Dr. Jessalyn Kupreja is the chief of lung transplant there. And so I worked with her a lot. And so I learned through working with her that, okay, I can be a woman and be a cardiothoracic surgeon. Like, here is someone who I see, and she's doing an amazing job of it every day. I didn't know anyone who had kids that was a cardiac surgeon. I didn't see people sort of managing all these things that I wanted for me. So it was hard. And I think because of that, it took me a long time to realize that that's what I really wanted to do.
And I imagine like now you can see yourself in that position to be a mentor for other people who want to follow. Right?
I do. And I mean, that's one of the reasons why I was excited to do this interview, because I think the visibility of, you know, I'm a woman and I do cardiac surgery. I'm a mom and I do cardiac surgery. And you can have all these things and you can do them. I didn't know that. Yeah.
So talk to me a little bit more about the hours that you're working in residency, because obviously like residency alone is tough, let alone surgery.
Yeah.
So what was that like?
So I was single for the first 3 years of residency, which made it easier in a way, I guess.
Sure.
There's sort of pros and cons, but you can just throw yourself completely into it. And so nowadays in residency, there is this 80-hour work week. So you're not supposed to be working more than 80 hours at a time. But I want to be totally transparent that I definitely worked more than 80 hours a week, because the more you are there, the more you get to do, the more involved you are, the more you're trusted. And then the more you get to do, the more you can do. And then the more you get to do, the more you can do, more you get to do. So the more you're around, you know, the more experience you'll get. And I'm not saying that programs that follow the 80-hour work week, I think almost all programs try very hard to follow the 80-hour work week, but that doesn't mean necessarily that if you want to stay, you can't stay. I think once you start getting into fellowship, it's really hard to, you know, because those are your final years before you like launch as an attending, which is a completely different experience where there is no 80-hour work week. And if something is happening, you have to be able to do it. And so, the hours, it's a lot of hours. But at the same time, you know, it's manageable, and there's ways to, you know, with, if your partners and your colleagues, both in training and then after training, are so crucially important. And so if there's some reason, you know, if you need to get to something out of the hospital and you have a good colleague that you're working with, and they can help you out, so you can go do that thing you really need to do, and then you can help them out when they, you know, then it's fine, as long as the patient is always taken care of. But yeah, the hours are a lot, but but you know, there's ways to manage it.
Were there times where you had those moments of self-doubt where you wondered, like, you know,
all the time,
am I going to be able to do this?
100%. I think that I think you have them, or I had them at like every stage, where it's like, oh wow, this is, you know, either you see someone a year above you doing something and you're like, how am I ever going to be able to do that? And then you know, you show up for work every day and you give it your best, and you study hard, and you keep track of what you don't know and what you need to learn and what you're not good at and what you need to get better at, and you keep just plugging away, and then next thing you know, you raise your head and you are that person. And you see the junior resident you're working with being like, how am I ever going to be able to do that? And you're like, oh yeah, that was me, and now I can totally do this. So I think fascinatingly, the way training is, it like builds a lot of confidence, because you are, every single day you are tested, and you get through it. And if you make a mistake, you learn from that mistake. So by the time you get to the end of it, you know, if you're well trained, you know that you can handle what gets thrown at you. And then I think a huge component, which now as a junior attending I'm experiencing a lot of, is you are also very aware of when you need to ask for help. And I think that's a whole other discussion about finding the right job after training. But I'm fortunate enough to be in a department that is incredibly supportive, and I have the help that I need when I need it, no questions asked.
That's amazing.
So it lets me take on big cases, because I know if I need help, it will be there.
So now you're a junior attending. Can you walk me through what your average day is like?
Yeah, highly variable.
Very nice.
So I have block time Thursday, Friday. So I'm operating on Thursdays and Fridays. And then I usually end up squeezing at least one case on my other days. Sometimes that'll end up being a late afternoon, early evening case, because I'll follow someone else who has block time. I have clinic on Wednesdays. So all day Wednesday I'm in clinic, hopefully seeing and booking patients for the operating room. Tuesdays is sort of a half academic a day. And then I also do endovascular work on Tuesday. So it is in a way is an operative day, but mostly endovascular instead of open surgery. And then Mondays is also sort of a half academic day. And then I also do TAVRs on Mondays. So, yeah.
Very nice. Are you involved in research a lot? And was that like a huge part of your training as well?
Yeah, it was. I did 2 years in the lab in general surgery, and I did a master's in epidemiology and biostatistics. So I'm involved in outcomes research now. And I found that degree was really helpful. Not that I remember everything from it, which I wish I did, but it just helped me realize how to ask a question and important things to think about when designing a study. And so now when I'm involved in multiple studies, I can draw on that, which is great. But I also have a keen interest in surgical performance and specifically peak performance of surgeons in the operating room. I think that, I played sports in college and then with my music background, I think that ability to really perform under pressure and communicate and think quickly and pivot quickly when necessary. I think those are things that are shared in the performing arts and in sports and in surgery. And so I'm very interested in the kind of mental preparation and visualization that can occur before any kind of performance, like an operation, and different biomarkers to help understand and then hopefully mitigate stress in those situations. But yeah.
Interesting. So what is that preparation like before you begin to cut into somebody?
Yeah, so it's changed for me over the course of the last couple of years as I've been in attending, which is interesting. I think it begins when I will do a final review of all of the imaging before I come down to the operating room. And while I'm sort of scrolling through all the scans and the CATs and remembering exactly what I'm going to be doing and what it looks like in radiographically, I'm building a picture in my mind of what I'm going to see when I'm down here. And then I'll usually take a few minutes upstairs in my office and just kind of think through the case and like what order I will do things in and what steps need to be done, what maybe specific things for this patient I need to remember at these points. And then when I come down here and do the timeout to sort of start the case, I will talk with the whole team through sort of all the main steps of the operation. First of all, to make sure everyone understands what we're doing, but also to make sure we have all the equipment available and the devices we might be implanting are here before we make an incision. And then while I'm scrubbing is sort of my final stage of prep where I'll just, take a few breaths while I'm scrubbing and think about what we're about to do and, sort of get myself into this state. And then one of the things I love about cardiac is all cases sort of start the same. You open the chest, you got the patient on bypass. And so it's fascinating to me, that sequence of just, it's the same way every single time. There's, like the 50 things you do in a row just to get them on bypass. And going through that really, it's like in a way, it's kind of like the warm up. You do the same warm up every time before you play the game or whatever it is that you're doing. And then when the game starts, you're like in the zone because you're ready. And for me, that like opening and getting on pump is that gets me ready.
Right. You mentioned a team, right? So who else are you with in the OR when you're doing surgery?
Yeah, I love this about cardiac so much. So your sort of immediate surgical team is one assistant, sometimes two, and then the scrub nurse who's handing you the instruments. So those are the people you're like touching and are right there with you at the table. And then the cardiac anesthesia, the anesthesiology team is on the other side of the drape. And that's usually here, at least an attending and a resident, sometimes an attending resident and a fellow. And they are, you have to communicate a lot because they're working the breathing machine, the ventilator. And so sometimes you need that turned off to see what's happening until you get on pump, and then you can just turn it off. But then they're also using the transesophageal echo probe to look at the heart. So you're doing a lot of communicating about what they're seeing. So you make sure what you've planned to do for the surgery is appropriate. And then as you're coming off pump, they're looking and seeing, was your repair successful? What does the heart look like now? Is there anything else we need to be doing? And then they're managing all the medications with blood pressure, which is really important for cardiac specifically. Then you have the perfusion team, which is running the heart-lung machine. And so as you're coming on and off pump, obviously there's a lot of communication with them. But then throughout the case, every 20 minutes or so, you're giving cardioplasia to keep the heart arrested so you're not, the little muscle cells aren't burning energy that they don't have because they're not getting oxygen because you've arrested the heart. So you as the surgeon, you're leading this whole, multidisciplinary team of people to get this patient through the operation. And while it is 1,000% a team effort, there can only be one person that's really in charge and running the show, and that's you. And so I love that component of it because it means you have to be a good and clear communicator. It means you have to understand what everybody is doing and anticipate problems that are happening. And while doing all of that, focusing on using your hands and technical skills to really fix this heart. So it's a case, it takes all of me, like all parts of me are engaged in that case, and none of it is easy, at least not right now.
I definitely wouldn't imagine it would be. So you mentioned like sometimes there's problems. So it's like a lot of people might think like, okay, surgeons are supposed to be perfect, right? So it's like, what happens when something goes wrong in surgery? Like, how do you manage that?
It's also a great question. I think that's where your leadership skills really come into play, because the tone you set just by your physical posture, by the tone of your voice, how you're managing the room when something goes wrong, that affects every single person in the room. And so you have to stay calm and focused. You have to let everybody know, like, okay, we're having a problem. I need everyone to pay attention, but in a way that is calm and focused. And then you have to think. You have to understand what the problem is that you're having. You have to understand, the 3 to 10 options you have to fix that problem. You have to make sure that you have what you need I didn't expect this to happen, but now I'm going to need these things in the room. We need to get this in here so we can do this. And you have to have your backup plan for if that doesn't work. And hopefully this is something that you've thought about before the case. So, this is what I'm planning to do, but if this happens, I will do this. And if that doesn't work, then I will do this. And so you just start working down your algorithm that you've pre-planned. But sometimes something completely unexpected can happen, and you just have to think about what the most important things are that need to get done and prioritize that. And sometimes the most important thing quickly just narrows down to saving this patient's life and getting them off the table. And so also understanding where that inflection point occurs and where maybe you're not going to do the 4 things you were planning to repair for this patient, but you're going to do the 2 things that you can do right now, and then you're going to, finish and save them and move. And so that ability to do that, I think, comes with experience, but also really understanding their physiology and the priorities of the case.
Do you have a specific case in mind where it was like a really good success story and it really reminded you like why you became a doctor?
Sure. Like my case yesterday.
Sure. Yeah.
I had this, and then maybe another case, which is a little more poignant, but I had a great case yesterday that was just, I had, all the teams are fantastic, but I was working with a particular subset of that group where we work very well together and everybody is on the same page and knows what's happening. And different people have different kinds of tissues, and some tissues are just a joy to operate on, and some are a little more friable and bleedy, and you have to be much more careful and gentle. And the gentleman I was operating on yesterday had fantastic tissue, and it was a great case. And I sort of did a little twist on the case that I've been wanting to do, and he presented the perfect opportunity to do that, and it worked great. And he flew off bypass, and he was extubated in a chair by yesterday evening. So it was just, and he looks fantastic today. So that was a real pleasure. And then I think then, you know, seeing these patients after the operation, and this is the difference, I think, once you graduate from training and become the attending is, you know, this person and their loved ones like grab your hand and say, thank you, like you did this. And you realize, oh, it did. I mean, it's a team effort for sure, but it's so satisfying. And so, you know, all the hours and the sacrifices and all that stuff, when you really get to help someone, it's amazing. But yeah, I had a different case a few months ago where a gentleman had a acute type A aortic dissection, which is where the aorta is like an onion. And sometimes there gets a tear on the inside and it splits and blood goes in between the layers. And then the blood doesn't go where it's supposed to go, like the brain or the organs or the spinal cord. And he came in with a type A dissection and lower extremity paralysis. So he couldn't move or feel his legs at all. And when I met him in the emergency department, you know, he was not in a good state. And I said, you know, I need to do an emergency surgery to save your life. I don't know that you will survive because there's a chance that you will not. And I don't know if you will ever move your legs again, but we're going to do everything possible. And then it then became this multidisciplinary effort to get him through. So he went to interventional radiology for them to stent open his aorta by his legs in order to restore blood flow to the legs. And then vascular surgery had to work on his legs to do something called fasciotomies to relieve the pressure so that blood could still flow to his legs since they'd been ischemic for a while at that point. And then the next day I took him to the operating room and did a circ arrest hemi-arch case. So where I cooled him down so I could turn the heart-lung machine off and then replace part of his arch in his ascending aorta where the dissection was. And then I also deployed a frozen elephant trunk, which is a stent graft antegrade from his chest but down his aorta to help stent open the rest of his aorta because he had a tear in the proximal descending as well. And then after all of that, he did amazing. And he walked out of the hospital 10 days later and went home. And I went and saw him on the day of discharge, and he, you know, was very emotional and was like, when we met, you said I might not survive and I might not walk again. And he said, I knew it. Like, I wasn't sure if I would get out of here. And then he was walking home. It was very cool. So that was a major moment. And something that I've done actually is because I don't always make it home for dinner, and my kids are young, they're 5 and 7 right now, I will sometimes bring them with me to the hospital on the weekends to round. You know, when my patients are doing well and it's sort of a very positive experience, and I'll take them around to meet my patients, which I've had so many patients tell me was such a highlight of their time in the hospital to, you know, see these like young, fresh little kids. But then it's also a chance for me to show my kids, you know, oh, do you remember 2 nights ago when I didn't make it home? It's because I was operating on this gentleman or this woman. And it really helps them understand why I do what I do. And I think that component of service and really helping somebody makes it worth it.
Yeah, it makes all the hard work and all the years. So you talked about these really amazing experiences. I imagine it's not all the time that you have successes.
That's right.
How do you deal with that?
It's really hard. It's really, really hard. I think it's important for me to talk to people about it. So I talk to my colleagues about it. I talk to, there's a core group of us here who went through advanced fellowship at the same time. There were 3 of us doing an advanced fellowship, one in just general advanced cardiac, one in advanced heart failure, and then I was doing my aortic super fellowship. And we shared a little office together, the 3 of us, and spent a lot of time together. And so we've stayed in touch since, which I think has been incredibly helpful because we share a lot of the stories we have as we're starting to build our practices about complications that we have. And 100% having a complication as an attending is a different ballgame than as a trainee, because as the trainee, you're never ultimately responsible. But as the attending, it was really you and only you that made that decision to do X. And if it doesn't work out, or something happened, or that wasn't the right decision at the time, it's hard. It's really hard. But I think talking to other people and realizing that, we're all only human. You make the best decision you can at the time with the information that you have. And as long as you're honest with yourself about your ability to make those decisions, and you understand when you need to ask for help, and you also have some grace for yourself that you're not always going to be perfect, and you realize that every mistake you make is a chance to learn and to know how to do it better. And certainly, the complications that I've had, there's always something to learn from them, which means they always change my practice slightly, which means all these other patients on whom I will operate will benefit from that complication, because I hopefully will never make it again.
Right.
And thankfully, I've never had a judgment complication where I made an incredibly wrong decision, because I think that's hard. But it's more, it's cardiac surgery, and catastrophic things happen. Tissue is friable and it tears. Right. Or you're trying to get somewhere fast to do whatever it is that needs to be done, and you don't quite get there fast enough. But when you can learn something from it, then you just have to remember all the other people that will come. And I think something I have, and I think most surgeons have this that I know, is I have a drawer in my office desk, which is, patients write to you and they send you thank you cards. I have a little collection of cards and letters and tokens or whatever from different patients saying, you saved my life. Thank you. And that, when it's a tough time, sometimes you open that drawer and you pull one out and you can read, it and remember that you're doing a lot of good.
You made a difference. Yeah. That's amazing. Yeah. What's your favorite part of this job? What's your favorite part of being a doctor?
I think operating is my favorite part. I think those moments when things are clicking and you, especially at this stage where I'm at right now, where you really know what to do and how to do it, and you're not in the throes of trying to figure things out, but you're more in the throes of trying to make it as perfect as possible. And I love that. And I love being able to lead the team through the operation.
And what is your least favorite part of being a surgeon?
Probably, but I don't know that that's my least favorite part either. Like, dealing with complications is really hard, but I think that hardness is also, like, I signed up for that. Like, I don't want to shy away from that. So that's not the worst part. I think, probably there's this sort of 5 to 10 minute period when maybe I'm on call and I'm at home with my family and we're about to eat a nice dinner or something, and then you get a call and you have to just immediately jump up and run away. The first 5 to 10 minutes of that is probably my least favorite. But then you start hearing the story of the patient and looking at the imaging and realizing what needs to be done and making a plan, and realizing that it's actually an incredible privilege to be the person that has the skill and the knowledge to help this person who's having the most terrible thing. Like, they don't want to come into your OR. No one ever wants to meet me.
Sure. Yeah.
So I think, that transition from sort of normal life into I'm a cardiac surgeon and I'm going to go take care of this problem. That little transition, I think, can be really hard, but it only takes about 10 minutes, and then you're you commit to it, and then you're fine.
What's the best piece of advice you've ever received in your entire training?
I think it sort of comes in two parts, but to try to squeeze as much learning out of every moment, because there's a lot of moments, and you're like, you work a lot, you're in training for a long time, but for every moment, even if you're just retracting and watching someone do something, to try to learn as much as you can. And then the other one is to, while you're doing that, when it's appropriate, to realize that, to never be afraid to ask questions and to try to understand more, because there will come a time, and it will come very quickly, where all of a sudden it's up to you, and you're the one making the decision. And all those moments of learning, and moments when you could have asked the masters around you, like, wait, what are you thinking? Why are you doing it that way? What about this? And, have you thought about, those are all opportunities to learn. But if you're so overly concerned with what they will think of you, or displaying your ignorance because you don't know the answer to that question, you just have to have a thick skin in those moments. But if you don't ask the questions, it's just such a missed opportunity. And then when the time comes, finally, when it's you, you'll be thankful for all those other learning moments before.
Awesome. So I think now we're just going to focus more on like topics within cardiac surgery, like whether it's like where's the future, innovation, where you think things are going, maybe talk about like interventional cardiology and cardiac surgery, like where that's going, like especially because you talked about doing TAVRs earlier, so I want to learn more about your perspective.
So I grew up in medicine in a fascinating time, because TAVR was FDA approved in the United States in 2011, and I finished medical school in 2012. And so when I was coming out of medical school, there was this, like death knell over cardiac surgery of like, but now there's PCI for coronary disease, and now there's TAVR for aortic stenosis, and probably at some point for AI. So, cardiac surgeries, they're not going to have a job anymore. And so it's been fascinating to have, as I was going through general surgery, it was still like, but like, are we even going to need cardiac surgeons anymore? And then now, we're about to have a dearth of cardiac, like there's not enough cardiac surgeons. And I think, the interest, as far as I can tell, although obviously I'm very biased, of medical students and surgery residents interested in cardiac has really skyrocketed, because it's become, I think, so clear that it's not going anywhere. And if anything, we're, progressing and innovating at such a rate that there's so many different areas in which cardiac surgeons are needed. So that's really fun. Yeah.
So for a student like me interested in cardiac surgery, how or what can I do to put myself in the best position for either the I-6 application or for any or for applying to this specialty in general?
Yeah. So I think exposure is huge. And then, getting and coming hand in hand with that is getting to know and work with cardiac surgeons. I think that, first of all, it helps you understand if this is really what you want to do. But then also, the more they know you, I mean, it's a tiny family, which the deeper I get into it, the more I realize how small it is. And that family starts now. Like there's some co-med students that I was in school with who are now also cardiac surgeons. And like, I see them all the time. And I never thought I would. It's like, we were, first year med students together, and now we're both cardiac surgeons, and you see each other at conferences and, end up on the same committees, and it's very small. And so the more people know you and the more you know them, everybody talks to each other, and it's very easy for me to be like, that guy from here, I know someone there. Let me call and be like, hey, what's your sense of this person?
Yeah.
So, I would treat it like all cardiac surgeons know each other. And so, any interaction you're having with anyone, you should, try to learn a lot from it and make it a positive experience. I think that exposure is really valuable.
Nice. So outside of the exposure though, what about like the technical abilities?
Yeah.
How do you develop those without actually getting to truly scrub in and work on the heart yourself before residency?
So I found, between the first and second years of med school, I worked with a pediatric cardiac surgeon in Toronto called Glenn Van Arsdale, who's down at UCLA now, but he was amazing. It was an amazing experience every day. I mean, I was like chart monkeying for him and writing some papers. But every day he would call me down to the OR when it was time to close. And for a while, he would close with me and sort of taught me how to do it. And then he would have me close with the fellow. But so I learned how to suture on these 6-month-old babies. And so he would say before he left, it has to be perfect. Like this scar will be there for, hopefully decades. So like make it perfect. And he showed me how to throw knots. He showed me how to suture skin. And and then he showed me how to first assist, which it's crazy. I still sometimes hear his voice in my head, even though, it was a very long time ago at this point. But but the skills that he taught me were reproducible in some ways out of the OR. One fantastic trick that he had was you peel an orange, and then you sew it back together. And so I think that helps in, for your 3D reconstruction, mental visualization component, you're thinking about like how to put that orange back together. But then, you're also using pickups and a driver to sew this thing back together. So for a while there, I was buying a lot of oranges and sewing oranges back together every night at home. And then he also had me tying with both hands. And so by the time I got to my surgical, I remember on my vascular surgery rotation as a third-year med student, I did an amputation with the chief resident, and we got going, and then he was like, "I'm sorry, like, what level are you?" And I said, "Oh, I'm a medical student." And he said, you know how to operate though. And I was like, "Yeah, I did this thing with this guy, and he showed me the oranges." And but then because I could do, it was this thing, the more you know how to do, the more you get to do, the more you know how to do. So it just becomes this like self-fulfilling prophecy. And so just knowing those basic skills, then translating that into the OR, then, I think I did that amputation as far as I can recall. At least, sewing everything back together at the end. And then that just tumbled into general surgery residency. You just get to do more and more.
Yeah.
But it all started with me at the kitchen table, practicing my knots and sewing oranges back together.
Wow. That's something else.
Yeah.
Yeah. I'll have to get started soon then.
Yeah, it's fun. It's actually quite, and it smells good. So,
yeah. So moving away from the training stuff, looking more into innovation now. Mm-hmm. So you said that CT surgery is here to stay. But we also see the innovation of minimally invasive procedures, transcatheter procedures that CT surgeons are doing. Do you think that sternotomy is going to become less and less popular, or is there still a place for it? Where is this all headed towards?
This is great. So, one of the reasons why I love aortic surgery is that it is both a combination of, the most minimally invasive surgery with all the endovascular repairs, but also the maximally invasive surgery, not just with all the sternotomy and root work that we do and arch work that we do, but also with the thoracoabdominal operations, which are, such a massive incision. So I don't think that open surgery will ever go away. I think that there are, now this is recorded, so in 50 years when we prove me wrong. But I think there's just certain kinds of operations which it will be really challenging to not do open. And some really delicate root work that I can't imagine finding ways to do it without an open surgery, mm-hmm. Which is fantastic because I think, many other surgeons don't do open operations anymore. And that is very sad to me. I love the old schoolness of cardiac in that regard. But at the same time, I think the endovascular work that we are doing now and the future of endovascular repairs is going to increase and become, even more fantastic what we can accomplish. So I think there's so much room for innovation there, and being in a specialty that is, actively changing the way we do things. It's fascinating, and constantly learning new things and new devices and new techniques, and being in a situation where sometimes someone is so high risk, you really cannot do an open repair for them. And then, that's okay, because then you have this whole, smorgasbord of different devices that you might be able to use. And even if you're not sure that it's going to work, you have to do something, and they won't survive open surgery. So it's a little bit, opens the door a bit to try some new things, which is awesome. And so hopefully helpful for them.
What are you most excited about the specialty then? Looking forward to the next 10 years, 20 years?
I think we will start doing, I think we will get very good at endovascular arch work. And I think there will be some, very complex aneurysms that we'll be able to treat through the groin, which is really exciting.
Okay. I remember I asked another surgeon this question, but 100 years ago or so, we didn't even realize that cardiac surgeons could be a thing.
Yeah.
So what does the role of a cardiac surgeon look maybe 50 years, 100 years from now? Do you have any idea?
I don't know. I mean, I would like to think that some of the old school cardiac surgery will always be, that there will be redo cases that need to be done, or a failed endovascular repair where the graft needs to be taken out and you need to come traditionally through the sternum. I think, I hope so. I don't know. I mean, it's sort of fascinating to know that a lot of the techniques that I use every single day were the same techniques that were developed with the first cardiac surgeons. It's very neat. Yeah. But I think that, there will be new and different kinds of minimally invasive approaches. I think that robotics will continue to grow within cardiac surgery. But I don't think open will ever go away. So I don't know, 50 to 100 years, maybe it'll have swung more towards minimally invasive and then only open for the really gnarly cases. I'm not sure.
Yeah. Speaking of robotics, I haven't really seen any in the department here at Michigan.
Yeah.
Is there a reason why?
Because we're starting it now.
Okay, cool.
No, we are. I think in the next few weeks have some robotic Lima takedowns, but then just very small incision for the actual bypass grafting to occur. So it's happening. It's going to happen.
Okay.
Yeah.
What do you hope that your impact on cardiac surgery will be as a surgeon?
Yeah.
Is it through leading or the impact you leave on your mentees? What do you hope that your impact will be by the time you retire?
Oof, that's a big question. I mean, I think all of those things, yes. And I think the biggest impact I want to have is the patients that I will help along the way. I think that I'm hoping my research in peak performance and mental preparation and whatnot for cardiac surgery will change the way we train people and allow us to become better surgeons as we're better performers in the operating room. I also hope, because I recently became the Cheryl Huey early career professor in cardiac surgery here. And that was an endowed chair given to me as a female adult cardiac surgeon. And in my presentation for the ceremony to accept the professorship, I went through a lot of the numbers and statistics of women in cardiac surgery, and it's crazy. It's abysmal. And it's like single digit percentages, which is mind blowing in this day and age. So I also hope that part of my legacy, as it will be, is to have encouraged other women to do cardiac surgery and to know that you can do it without sacrificing every part of your life. That it's still possible to be yourself and have the things that you want while being a cardiac surgeon. So hopefully, 50 years from now, may we all still be alive, that I'll see that there are many more women in cardiac, and that some of those will be women that I inspired to go into it.
Yeah, there we go. That's awesome.
Which feels a little weird, but that'd be great.
No, that's great. That's a great response. Yeah.
Thank you so much, Dr.
You're
Hamilton.
So welcome. It's really my
it's really great to have you.
Thank you.
Best of luck to the rest of your career.
Thank you.
And yeah, hopefully everyone watching anyone's interested in cardiac surgery, this is who to aspire to. But yeah, thank you so much.
Great. Thank you.
Perfect.